Good afternoon. It's my pleasure to present another case. So I'm going to present a male patient, 57-year-old at time of diagnosis with a normal BMI, so no overweight, BMI of 23 kilogram per square meter. And his first polysomnography indicated an apnea-hypopnea index of 35 per hour sleep. He had a medical history of nasal surgery in another hospital 15 years before. And of course, based on that diagnosis, CPAP was proposed and started. But then, in the months thereafter, the pressure of the nasal mask on the face was troublesome. Another problem was that the partner thought of CPAP as being too noisy and that, again, they could not sleep in the same room and so on. So the main reason...
I had a question before you go to the next slide.
So anyway, the patient came to the outpatient clinic with a specific request for a CPAP alternative.
My question would be to the audience, what strikes you in this case?
That he has such a low BMI and has to have such a high pressure.
Pressure on the nose, that was the skin pressure.
Yeah,
not the
it is like not tolerating the mask and getting some pressure ulcers or whatever on the skin, on the facial skin.
I agree.
Yeah.
Low BMI.
Yeah.
And
yeah, but it was like he was not tolerating the mask on the skin. It's not about having a blocked nose. Yeah.
Here, Maria.
But I'm missing what were his complaints. Because we're not treating a number, do we?
That's right. But you will see he had the sleepiness as well as a loud snoring. It was a classical case of sleep apnea.
Well, it's too noisy. What is it? Is it the CPAP too noisy or is it
the CPAP
snoring?
machine in the room?
Okay, so
and I must add to that, we recently did a study on a large series in our hospital, sending questionnaires to people that quit CPAP sooner or later. And apparently in that series, the fact that the CPAP machine still nowadays is troublesome in terms of noise in the room for the partner is still a major complaint in the reasons why they quit or they want to stop CPAP. It's underestimated, in my opinion.
But the low BMI strikes me. Sorry.
Were there any craniofacial abnormalities on inspection, retrognathia, anything like that?
Not really. He was a thin guy with probably an anatomy that was unfavorable and in developing of sleep apnea.
What strikes me is to have this relevant sleep apnea in such a slim person. I mean, it's a BMI of 23. It's not 26
But that's
or
also another reason why I wanted to present it, because I think it's not a typical case, but it's a persistent sleep apnea, because you will see in the case report every time again we measure a sleep apnea. So it's not like it was overestimated or something like that.
If I can comment on that, like BMI of 23, I have like a lot of tiny petite women that barely weigh 100 pounds, which would be like less than 50 kilos, and they have severe sleep apnea. So I think like nowadays, we're actually looking at sleep apnea no longer as a disease of overweight older men. I think it's actually a disease that actually spans a wider population of people. And so I think like actually, Joachim, to your point, 23 BMI, I see a lot of patients with severe sleep apnea with BMIs less than 25. So
I would say it's a minority, but you will see it anyway.
So was he able to use the CPAP every night, and for how long?
He was trying to do that, but because of the reasons that were on the slide, he had trouble doing that, so he wanted to stop. So he probably used it, but he didn't want to use it after a while. Yeah.
Yes, one more.
I'm not sure which nasal surgery has he done, and also have you done any endoscopy from the nose down to the larynx?
Yeah, I'll come back to that because of course, we now are going to do some more examination, in particular drug-induced sleep endoscopy also he had. And the surgery looked like a classical septoplasty, but he still had some septal deviation. Still had it. Yeah.
May I still ask one question to the audience? Who of you would go for CPAP in that patient first, or who would go for extended airway examination, let's say anatomy and function of the airway? Because he says, we said it can happen in slim people, but there must be a certain anatomical or whatever reason, and would try to do another treatment first, before CPAP. Who would go and look for other treatment options, not CPAP, as a first line? So quite a relevant number.
I have a comment that nowadays, because this case dates from some years ago, I think nowadays, 2018, we would probably also talk to the patient and say, maybe you don't need to go for CPAP per se, and we might do the drug-induced sleep endoscopy up front. In particular, when a patient would say, yes, I'm willing to undergo some examination to see whether another treatment might suit me, a more anatomical treatment or a mandibular advancement device or whatever. Maria?
In that case, like what you talked about, for example, in the United States, we cannot do anything other than unless the patient has failed CPAP, other surgical options might not be available. Or for mild CPAP, would be an option.
Okay.
But it's not going to be, so it's like trying surgery before CPAP.
That's more a national guideline issue.
Yeah,
so we have the same here in UK. The NICE guideline states that if you have a patient with moderate or severe sleep apnea, you should offer them CPAP as your first option. But it's the way you offer it to them. So if they go to a chest physician, they'll get CPAP first, undoubtedly. If they come to us, we may discuss alternatives if they fail CPAP, but we get them to try CPAP for 3 months.
You just ask them, do you want this beautiful mask, and sleep with it
every night
next
for the rest
to
of your life?
Your spouse, and with
maybe
a gentle blow
Professor Rambaud, can I ask you to comment on the Belgian situation?
I agree with Joachim. It's not always the CPAP, the first-line therapy, but if you can imagine a surgical procedure after, I think that with the CPAP you will protect your patient from many things. So in our institution with SO 35 IHI, we will start with a CPAP, with in mind that we are going to propose something else after.
Yeah, and of course there is a national difference. I'm aware of all the countries in let's say in Middle Europe, that in Belgium it would be different in terms of reimbursement as compared to UK or as compared to the Netherlands, as compared to France. In Belgium in particular, nowadays we would have reimbursement, and we don't need to prove CPAP intolerance when we would want to start an oral appliance therapy. But this has changed, so we could actually, based on that reimbursement rule, start mandibular advancement device instead of CPAP right away without. But of course, we need approval from the sleep physician. Okay, so to go on with the case, we then, because of the fact that the patient asked for an alternative, we scheduled a drug-induced sleep endoscopy that actually was, I would say, invented in this city, where you see the picture of the Royal National Throat, Nose and Ear Hospital. And actually, when we would have these patients with an AHI of 35 in our hospital, we would advocate to think that maybe a mandibular advancement device is the first-line alternative because of the higher AHI. And then we would propose like added part of the drug-induced sleep endoscopy with a simulation bite that we are going to put in the maximal comfortable protrusion, and we'll bring that to the operating theater. And then it comes to this kind of images where you have the baseline finding, for instance, an anterior-posterior collapse at the palate and an anterior-posterior complete collapse at the level of the hypopharynx with the epiglottis. And then the yellow squares are the changes that you would see as compared to baseline, putting the patient with a simulation bite in maximal comfortable protrusion, and we could illustrate that there was a statistically significant association between what you would see in terms of reopening, partial reopening, complete reopening at one or more levels that are collapsing at the baseline. So at the end, you need to say whether you think your patient is not or partially or well suitable for a mandibular advancement device therapy. And so in this case, we had baseline loud snoring with palatal flutter. We had apneas with multi-level collapse, a complete anteroposterior collapse at the level of the tongue base, at the level of the palate. And by collapsing, the tongue base took the epiglottis with him, having also an indirect or passive collapse of the epiglottis. With the simulation bite in that maximal comfortable protrusion, there was still a partial collapse at the level of the tongue base, as well as at the level of the palate and the epiglottis. So our advice towards mandibular advancement device therapy was moderately favorable, and so partial in between. But the patient, he got to know the results, of course, and then he preferred to start with this non-surgical alternative, being a mandibular advancement device. I guess you are all familiar with it, and that we hope that in a good responder that we can have an increase in cross-sectional area as well as at the level of the palate and the tongue base hypopharyngeal. But in this case, he still had residual snoring and sleepiness with the mandibular advancement device, and the polysomnography with the mandibular advancement device in the titrated position, which is the one that he felt comfortable with and had the less snoring and the less sleepiness, still had an AHI of 12. Can be a discussion that coming from 35 going to 12 is not too bad. We would call that probably a treatment success, but it's not that good, also taking into account that there are still symptoms. There was a positional obstructive sleep apnea component with the definition here used, that this means that the AHI in the supine position is at least twice as high as the AHI in the non-supine position. And then we were looking back at the baseline polysomnography, and it occurred to us that he was a real POSA patient. And there might be another explanation, Joachim, to the fact that he had a 35, AHI of 35, because if he would not sleep on the back, he only had an AHI of 8. So therefore, because of the fact that he was not that good with a mandibular advancement device, we suggested him to use a more modern sleep position trainer that is from the company Night Balance, and is a chest-worn device, as you can see here. It's a very small and light device, and that will have a vibration when the patient is in supine position, and that vibration will continuously occur until the patient goes to one of the non-supine positions. And so he had a polysomnography afterwards with this sleep position trainer, but still had persistent snoring and an AHI of 17. But because of the fact that he had a POSA also with his mandibular advancement device, I would like to refer to this, but many people already said it, that why is it that the treatment in the treatment of hypertension, for example, medical world easily accepts to prescribe 2 or more drugs to reach a target blood pressure, while in the treatment of OSA, combining treatment options is somewhat under-evaluated or taboo. And so in this case, we decided, so he had baseline 35 and a severe POSA, with mandibular advancement device 12 per hour, with SPT 17 per hour, persistent complaints. And then we combined the treatment, MAD and SPT, and he had an AHI of 3 per hour, and he was very happy with it also in terms of the symptoms. So it's just to illustrate that sometimes 1 + 1 is maybe 3, and that we need to think about combination, but it can be a combination of a surgery and an SPT or an MAD or whatever. It's not focusing on this particular combination. Concerning this particular combination, we had this study with all of the patients having a residual POSA while being treated with an MAD. So there's a median AHI going from 21 to 11. We examined all those 20 patients with an SPT, Interestingly, they had the same AHI on a median as with their oral appliance, but then combining it, it's not only better than the baseline, but the combination is statistically significantly better as one of the monotherapy. The paper is open for discussion. I'm not sure whether there are any questions.
Any comments
from the audience?
Maria? Use a mic, please.
You have a epiglottic collapse, an independent epiglottic collapse. So would you have considered something like epiglottoplexy, for example, as a part of a combined therapy?
I think if this patient would not be happy with the combination of two non-surgical options, which is the case, oral appliance with a sleep position trainer, then of course, going back to the dyes, there are some surgical options. He had an AP collapse on all the levels, so I think theoretically, also with a low BMI, hypoglossal nerve stimulation would be another option, and then we could discuss that. Yes, of course.
Any other comments? There's one here, Jay.
Question actually. You did say that 15 years after the nasal surgery, there was a persistent nasal deflection, a septal deflection.
Yeah, moderate.
Number one,
moderate deflection. Yeah.
Is it significant? Number two, what is the assessment of the nose per se? I mean, we're talking about nasal surgery in this discussion. What was done in the nose? Do you think what was done was adequate? And I've got another question for the panel. Now, when we talk about doing DICE, all right, if a patient has got a badly obstructed nose, we know that if you're going to follow Starling's theory where it's going to change the pressure and the resistance further down, do you think there's going to be a change in DICE before and after nasal surgery?
Yeah, I would like to first comment on your first question. In general, whether yes or no there was a surgery done before, if a patient in this case coming to us for snoring and sleepiness, and he has no complaints or no important complaints of nasal breathing, I would tend not to think that at that point, with a normal clinical examination or a moderate, only moderate deviation, I would not take into account too much the nasal treatment, because I think in this case, on the contrary, if this patient has an important complaint of nasal obstruction and you would see nasal congestion, he would need a proper assessment in terms of allergies, in terms of maybe also CT scan, and then I think a septoplasty with radiofrequency of the terminus, for instance, could be part of the treatment plan. But it's my personal approach.
But I think the end of your presentation showed us that your combination therapy was extremely successful with an AHI of only 3 and almost no daytime sleepiness anymore. That's right. So that's what we wanted to achieve. I think our job as, let's say, sleep physicians or surgeons also is not in all cases to perform any kind of surgery. We have just to offer the patient the best way for him to get his sleep best as possible. And I think this is a wonderful example for that. Congratulations.
Thanks.
I think the only other comment I would make is that if you are trying to persevere with the patient using maybe nasal pillow CPAP, then the nasal surgery, further nasal surgery might help. And your question and comment about DICE before and after septal surgery or nasal surgery, there's variable results and variable data in the literature. Some papers have suggested there's a change. I've done a lot of it myself and looked at it and have found that the dynamics does change, but whether it's because of nasal surgery or whether it's because of correction of the lower part of the anatomy is debatable.
Should I go on?
Olivier?
Yeah.
Just one quick question. You have a huge experience with MAD. What is the compliance with MAD and with the positional therapy both together?
Yeah, thank you for that question. I would say that in particular the sleep position trainer has a very high adherence. So there are up to 1 year follow-up in the responders. So you need to take into account what we always do is a 1 month trial, because small half of the patients will not be happy maybe because of the objective problem that you measure is not a real improvement, but also subjectively. Some cannot tolerate the belt. Some partners even hear the vibration and it's disturbing for them. So in our study, we had about a big half of them really going on, buying the treatment, and then in that particular subgroup of responders that are really going on and deciding themselves to have it, that there is a adherence higher than 90%. In oral appliance therapy, we do know that in the first 3 months it's about 90%, but there is some decrease over time. But still, in all the studies that I'm aware of, it's much higher, I would say, I dare to say, as compared to CPAP, if you take a whole group of patients. But there, the individual disease alleviation is the most important. If a patient has a CPAP and uses it every night for 6 hours, 7 hours, then probably still CPAP is the best for this kind of people. But in turn, if you have a mandibular advancement device and it's only maybe a moderate decrease in AHI, but he uses it for the whole of the night, and the CPAP would only be used for 2 hours, then the disease alleviation would be in favor maybe of the oral appliance. So it's something that we need to look at in the individual patient in particular. Yeah.
Okay. Do you want to present your next case?
It's like you wish.
If you just
okay.
do a brief presentation.
Okay. So the next presentation is on upper airway stimulation. And so we have this male patient, 23 years old, BMI of 25.5 kilogram per square meter. And the particular thing in the medical history is a patient with Down syndrome. He has an overall handicap calculated of about 88%. Atypically, he had no cardiovascular problems, which is atypical for this kind of patients. And the clinical ENT examination was pretty normal, I would say. Median septum, no congestion in the nose. Grade 2 tonsil, normal uvula, malampathy grade 4, and a narrow palate. And he also had a maxillary hypoplasia. And so he had a baseline polysomnography elsewhere in another university hospital in Belgium with an AHI of 34 per hour sleep, mainly obstructive apneas, and I think very important, he had a very important minimum oxygen saturation, deep decrease. So the diagnosis of a severe obstructive sleep apnea was there. And of course, the first choice therapeutic option is a nasal CPAP. This had a theoretically, during titration, had good outcome, alleviation of the apneas, but the problem was that the parents, because of the Down syndrome, needed to be aside all of the night, every time over and over again, they needed to replace the mask. And so the parents came to us and they were exhausted. One of them always was sleeping with the patient in order to try to have the CPAP in a normal way. So there was a cry for help for alternative treatment. We did a reassessment 2 years after the baseline, which confirmed actually a very severe sleep apnea, HI 62 per hour sleep, again, some important minimum oxygen saturation of 71, and it turned out to be highly supine dependent. But then again, because of the Down syndrome, a sleep position trainer was not tolerated at all. He was just putting it off all the time, so this was not an option. We then performed the DICE, a drug-induced sleep endoscopy, flutter of the epiglottis, also a multi-level collapse, a complete anterior-posterior collapse at the level of the palate, a partial oropharyngeal lateral collapse, and a complete anterior-posterior collapse at the level of the tongue base. And so we thought, after a serious discussion on the multidisciplinary board, to talk to the parents and to propose them a treatment with hypoglossal nerve stimulation. And so at the end, we all agreed on that, and so the patient got implanted and activated. And then the titration night illustrated that in the final settings, we had a AHI of about 11. And remember, we came from about 60 at that last baseline measurement. Still, there was a component of positional sleep apnea, so 14 in the supine position as compared to 3 per hour in the non-supine under upper airway stimulation. But quite an improvement in the oxygen saturation. And so, of course, there is a persistent mild OSA, mainly supine dependent, but a decrease from 61.4 to 11.5 means change in AHI of 81%, which is, of course, very important and significant. And so to give you an idea, this comes from this particular patient where we had a period during titration night with the stimulation off, where you can see that there is indeed the oxygen desaturation, the apneas, and then with the stimulation on the EMG, of course, this is representative for the stimulation of the hypoglossal nerve, and we can clearly see that there's a normalization of the flow as well as of the oxygen saturation. And to finish, and we were talking about not only looking at the AHI, and I think this is very representative for that. This is a letter from the parents. My name is Julien. There are so many things I'd like to say, but this is hard for me, so my parents will do this for me. Our son Julien is able to sleep again at night and enjoys every single moment. He laughs, makes a lot of fun. Sometimes he makes beautiful sentences, and almost every day he says thank you. We can see our son shine again, and all of this thanks to you. We are very happy with Julien and are satisfied we did choose to undergo the implantation. What a convenience for Julien, but also for us. We can now sleep again ourselves. It's, of course, a particular case, but I thought it was interesting to present it to you.
Thank you very much. Thank you, Olivier.